I think most people know something about diabetes, that there's a raised blood sugar and that it can affect the eyesight. In this short video, I'm going to tell you a little bit more about all of this, about how our current treatments work, and to give you some pointers as to our future research directions. Diabetes is a very common condition. The WHO estimates that there are around 450 million people living with diabetes in the world today, and that this is going to rise to 700 million over the next 35 years. There are also quite a lot of people living with diabetes in the UK. We think between 3 and 3.5 million, and that this is going to rise to about 4 million in the next 10 years. I'm afraid that diabetes is still the commonest cause of blindness in the developed world today in working age people. But I don't want to scare people with diabetes too much, because certainly, at least in this country, we've made very substantial progress. We're detecting the condition much earlier at a stage at which it can be treated through our screening program. And also, we have very good access to the latest current treatments. So let's have a look at a cross-section of the eye. And you can see that I've highlighted the retina with these blue arrows. The retina can be seen by an eye specialist and an optometrist by looking through the pupil. And here's a picture which shows the optic nerve, which is the nerve that takes the messages of sight processed by the retina back towards the brain. The center of the retina is called the macula and is roughly shown by this circle. When diabetes affects the retina, it's known as diabetic retinopathy. And when it affects the macula, which is part of the retina, it's known as diabetic maculopathy. So how does the high blood sugar damage the retina? Well, you saw on the last picture the retinal vessels, and most people are familiar with arteries and veins within the tissue of the body. They're connected by fine vessels called the capillaries, which are shown in this diagram. The capillaries are very sensitive to the high blood sugar, but they can really only do two things. They can either close or they can start to leak. The closure results in the retina becoming starved of oxygen, while the leakage causes the retina to become waterlogged. So what does this look like in the retina? Here you can see some changes within the retina caused by the oxygen starvation. You can see some hemorrhages in the left hand of these two images. And then, if left unchecked, new blood vessels start to develop, shown in the image on the right. The leakage problem tends to affect the macula to a greater extent, and you can see some leaking fluid which has precipitated, causing these fatty deposits on the left hand of these two images, while on the right you can see that this has developed to a very advanced stage. We can take other types of pictures of the retina, and some of them are very good at showing retinal thickening. Here is a cross-section of the retina shown on a device called an optical coherence tomogram, or OCT, and you can see the normal depression in the retina in the upper panel, while if you look at the lower panel, you can see how, and this is from a person with quite advanced diabetic retinopathy, you can see how the fluid has started to accumulate, causing the retina to become thickened. Now, this change starts to affect the sight quite significantly. There are two main treatments for diabetic retinopathy: laser and intraocular injections. And I'll talk about the laser first. On the left, you can see the laser burns applied to the retina. This is done over typically 3 sessions over a couple of months. Laser treatment is very effective, and it's been around since the 1980s. The way it works is by reducing the oxygen demand of the retina, and that results in the blood vessels regressing or clearing completely. Intraocular injections have been around for about 10 years, and they work by reducing the amount of leakage and helping the capillary to function normally. There are 3 common drugs used: Lucentis, Eylea, and Avastin. and also some steroid implants that are used for the more severe cases. So here you can see somebody with a really quite severe case of diabetic retinopathy. You can see these yellow deposits within the retina and lots of hemorrhages. And after 9 of these injections, plus 2 laser treatments, you can see that the situation has improved dramatically. And I'm pleased to report that the vision improved from just below the driving standard back to normal, but it did take 12 months for that to happen. Now, occasionally people need an operation. You can see here a quite advanced case with scar tissue and hemorrhage. And this can be treated by an operation called a vitrectomy. Small, fine probes are inserted by the surgeon to treat the retina and to remove the blood. This isn't needed very often in the UK, but is more commonly needed in the developing world where people tend to present quite late. I'm going to finish off by talking a bit about some of the research that's going on. Many of you have been involved in clinical research projects, and we're lucky in the UK that so many people volunteer to help with the development of new drugs. In Liverpool, we have a clinical eye research centre linked to our unit, St Paul's Eye Unit, in which we've been able to test and develop and optimise most of the drugs that are now available, including the 3 treatments for diabetic maculopathy. We also have a team of laboratory scientists working on new treatments for diabetic retinopathy. Unfortunately, some people don't respond to the treatment that we currently have available. In one of these situations, there's been so much damage to the capillaries that the retina is substantially starved of oxygen. And we have no treatment for this particular situation. So the idea is to take stem cells from a person's peripheral blood, transform these cells in the laboratory, and then use these to repopulate and reline the blocked capillaries. So we're making steady progress with this, with a number of partners elsewhere in the UK, and we'll be taking stem cells and testing them in clinical studies in the next year or 2. And finally, a word about another big challenge facing the world in dealing with diabetes. We now, as I said, have hundreds of millions of people with diabetes, and really they need their eyes examining on an annual basis to have any chance of detecting their retinopathy at a stage at which vision loss can be prevented. So we can apply artificial intelligence and computer technologies to automatically assess these images, which currently have to be examined by a trained retinal grader. So this really could open up the chance to deliver screening across the whole world. Also, the point about having to take photographs or do an examination every year. Well, it's possible to apply some modern statistical technology to develop a risk calculation engine, which uses the information from the person's eyes together with their diabetes control and some factors like their age and duration of diabetes to work out their own personalized risk. And that would allow most people to have to be seen for screening maybe every 2 or 3 years. This technology is known as personalized screening and is coming into diabetes very rapidly. So I hope I've given you some useful and interesting insights into how diabetes affects the eye and what we can do about it, and at least a flavour of some of the exciting new treatments that are being developed to deal with those remaining outstanding challenges we've got.